Lovely. So thank you very much for that lovely introduction, Annika. Very good. So I'll start a little bit with some context, and Andrew helped me out earlier by introducing the theme of common variant susceptibility, which is largely what I'll focus on. We've had a good kind of 20-ish years national universal screening programs for breast, colorectal and cervical cancer, and more recently the addition of screening for lung cancer in selected groups. But as a clinical geneticist, we can access and offer additional interventions that are not clinically acceptable or economically feasible to offer at population level if we can identify a group at elevated prior risk. So in terms of screening, and thinking breast cancer is a good example, we'll offer them MRI rather than just mammography. We'll start that at 30 rather than 50, and we'll do it annually rather than every 3 years. There are other interventions on top of screening, or as an alternative to screening, we can offer patients we deem at high risk. We can offer them risk-reducing surgery, in particular mastectomy, to mitigate the risk of breast cancer. We can offer them chemo prevention, and again, there are agents that we use for those at high risk of breast cancer. And we can advise behavioural interventions. So this is a schematic of the genes that we test for breast cancer in the clinic. The ones we test most commonly for are those, and probably the most sort of impactful are BRCA1, BRCA2 and PALB2. But these are not very common in the population. That's the population frequency of each of those genes. So if we're really looking to sort of get in there and find people at risk in the population, that's only a tiny sliver if we went looking for these types of genes. Even that larger group, they're just pretty infrequent. So again, we get another little tranche of the population, but these are very infrequent. So you're not going to make big inroads in cancer prevention. So the enthusiasm would be to look at common variants, and the challenge, the question is, can we, possibly in combination with non-genetic factors, use common variants and non-genetic factors to identify a bigger chunk of individuals who are at risk, to whom it would be impactful to offer interventions, that more intensive screening or even possibly the other interventions. And this sort of has very much come to the fore for a number of reasons. Over the last 3 or 4 years, the National Screening Committee, their remit has officially changed. It was very much had to be universal screening, and then in 2022 there was a quite official shift, in part around introduction of lung screening stratified by smoking status, in part adaptation of cervical screening around HPV status, but there was very much a remit handed to the National Screening Committee that they should look to targeted or stratified strategies. In addition, the articulation of the NHS long-term plan, a real focus on cancer early detection, with this target that 75% of cancers should be diagnosed at stage 1 or 2. They set that at 2028, which was highly ambitious, and I won't divert, but it's a target that lends itself to diversionary tactics, but the ambition is ultimately to improve survival, improve mortality, and they have framed that as increasing early stage detection. These national screening programs are very intensive and very expensive and use a lot of resource, and so there is an enthusiasm that they could be rationalised and restricted or better targeted to individuals identified to be at high risk. And there are many cancer types, and there's a sort of real prostate cancer in particular, there's a real drive to introduce prostate cancer screening, but also these cancers with very high mortality and there's a high unmet need, cancers like pancreatic and esophageal cancer. Can we change outcomes if we can find them earlier? So, moving on, so polygenic risk scores. So Andrew introduced the concept of genome-wide association studies. So these are case control studies where you compare a large number of common genetic variants and their frequency in cases, individuals with disease, and non-cases, individuals without disease, to find associated SNPs. Genome-wide association studies, as Andrew demonstrated, were highly successful, delivering dozens or even hundreds of common variants associated with disease for many, many conditions. And then this moves on to the second question is, can we implement these clinically, these valid scientific associations to be clinically useful predictors of risk? So what is done is you take all the associated SNPs for a given disease and weight them for their frequency and effect size, and together that is called a polygenic risk score. And these are quite dynamic. As more variants are found, your polygenic risk score is updated. So the current sort of working breast polygenic risk score has 313 core associated SNPs, and Richard Halston will correct me, I'm probably out of date, but for colorectal cancer, I believe it to be 87. So how do you evaluate a polygenic risk score? So this is a disease prediction test. So actually the standard way you evaluate any disease prediction test is via an AUC, an area under the receiver operator curve. So a perfect test, am I getting, yep, over here has an AUC of 1, and any value clearly differentiates whether an individual is a non-case in green or a case in purple. A totally useless test has an AUC of 5, and the curves are completely overlying. And nearly every test, every type of diagnostic or predictive test, would be somewhere in between, where your curves are somewhat overlying, so you would have an ambiguous area within the distribution where that test value would relate to both individuals who are cases or will be cases, and those who will not be cases, non-cases. So these are the current polygenic risk scores for prostate, breast, colorectal, and lung cancer, so the 4 most common cancers. So you can definitely, there's definitely differentiation between the two curves. So in each case, the cases are dotted and the non-cases are full lines, but they're not massively separated. And you can see that corresponds to the respective AUCs, sort of down here, lung at 0.55, and the top performing cancer in terms of the AUC is prostate cancer. So the way in which you would then use this in practice is you would set a cutoff in terms of the score. As for any diagnostic test, you have a threshold that you act on. Within that threshold, you'd then have a proportion of true positives, those who are, or in fact will go on to become cases, and those who are not, your false positives. So arbitrarily, if we said, let's put our threshold at 20%, the top 20% of PRS, you'd get roughly 20% of the population would be your false positives, those who will never go on to get disease. And the question, as with any other diagnostic test, how many true positives are you getting for your buck? So breast cancer is one of the best studied cancers. The AUC is 0.64. So if you put your threshold there, you tolerate 20% false positives in the population, you'd get 37% of your breast cancer cases, whereas 63% would be left in that area of low risk or non-high risk. That's assuming, that's sort of based on it being a case-controlled distribution. This was me trying to recreate curves, not very well. Obviously, there are far fewer cases than controls, so actually those curves should be sort of adjusted for the respective sizes. So can we use these polygenic risk scores to help in our sort of paradigm of identifying people at high risk of disease, high risk of cancer, and doing more to screen for early detection or mitigate disease? So what are the things that we need to think about around this? I think one of them is inherently, and this gets a little bit lost in our excitement for genetics, and again, Andrew presented this earlier, is that actually we forget that most common diseases, and certainly common cancers, have quite limited heritability. So this is based on twin studies, quite recent twin studies. So breast cancer is got a heritability from twin studies of about 31%. So this 69% is all environmental factors. So your polygenic risk score is going nowhere near that. But of that 31%, some of it is common and some of it is rare. So this is a nice pie chart shared by Antonis Antoniou from Cambridge. So in terms of your common variants, the polygenic risk score that we have already is shown in yellow. That's about 25% of that heritable chunk. So that's 25% of the 31%. So the current PRS for breast cancer is telling us on about 7.5% of what's driving the etiology, what's driving whether breast cancer will occur or not. If we did the infinitely large GWAS across the cosmoverse and found infinite numbers of people and all of those common variants, many of which will have minuscule effects, we'd get to about 43%. So 43% times the 31, that ultimately, in the sort of fantasy polygenic risk score for breast cancer, it would tell us of about 13% of what was driving disease, which then sort of explains, and this is a nice piece of work done by it's Zhang et al., it's Montse Garcia and Nylan Chatterjee, that these are your current AUCs here. And there's a lot of talk, well, when we do bigger GWAS and so forth, we'll get more and more, we'll get better PRS. But essentially, we are constrained ultimately by that heritability. So modelling from the current PRS and size of studies, you can predict what you'll get to if you did a GWAS fourfold larger than the current largest meta-analysis. It doesn't get you that much higher, and then this is if you could infinitely get every common variant, regardless of how small the effect size was. So again, the less studied cancers, you've got more room to go, but actually the bigger cancers, there isn't that much, even if you did these enormous GWAS. So that is the first factor we need to consider, is to recognise the impact of heritability. The next factor, and this pertains actually to all issues around cancer screening, is you have this inherent tension. Cancer is a disease of ageing. If you want your screening to buy you life years, then you want to screen young. So that is always going to be a tension, that actually the proportion of your disease arising in these younger age groups, particularly under 50, is very, very low. And for many cancers, particularly colorectal, pancreatic, near enough half of those cancers are arising above the age of 75. And you'll be pleased to know, with COVID, austerity, the last government, the actuarial contemporaneous life expectancy has dropped. So actually for males, it's just coming below 80. So you can see that your ability to impact on mortality for these cancers, particularly of older age, is really quite limited, which gets to thinking about cancer-specific mortality versus all-cause mortality. So you may do something, you may stop them dying of colorectal cancer, but it may be that you don't actually change the age that they die at the same age they would have done. You've just shifted the cause of death when you're operating at the older age groups on a population level. So this links into that actually the ages in which you may well be implementing your intervention, the absolute risks may be pretty low. So let's look here. There's a lot of focus on bringing the breast cancer screening to younger women. So what would happen if we screened age 40 to 49? Well, actually, your 10-year risk in the population for women that age is 1.7. Even if you focused in, so let's concentrate our efforts, just do that top 20% on the polygenic risk score, efficient use of resources, their 10-year risk is only 3.2%. It's still quite a modest risk, even in that high-risk quintile. And then you think, actually, well, you've gone from there's 4.3 million people in that age group, you can restrict down to it only being 870,000 you include, but you also lose 63% of the cancer, so you're only targeting 37%. So again, the maths are challenging when your absolute risks are low. Same for colorectal cancer. There's a real drive to bring down colorectal cancer screening. Currently starts at 60. They want to bring it down. Could you work with polygenic risk scores? Again, the absolute risks are low. And even in your top 20% of your top quintile by polygenic risk, it's less than a 1% risk over 10 years. So again, that's pretty low frequency. Large numbers, even if you restrict it to the top 20%. And again, by doing that, the majority of your cancers are happening in the people you told were low risk. So again, that's showing the impact of the limited predictivity of the polygenic risk score combined with those quite low absolute risks. You have the same problem once you move outside those common cancers. Pancreatic cancer, high unmet need, but actually your lifetime risk, only 1.7%, and those who are listening, half of that risk is happening above the age of 75. So again, we might want to screen for pancreatic cancer age 50 to 60, or maybe 60 to 75. Your 10-year risks are really quite small in these groups. So, that's less than 1 in 500, even in your top 20%. So again, you're having to screen very large numbers of people. If you do it based on polygenic risk score, you're leaving the majority of people unscreened because you've told them they're in the low risk, the non-high risk group. And again, relatively modest numbers targeted. And this is assuming we had a good screening tool for pancreatic cancer, which we don't. This is the risk stratification. So again, very challenging around those low absolute risks, either in younger ages or for the less common cancers. So again, one of the sort of solutions put forward is you don't just have a polygenic risk score to risk stratify. You'll bring in lots of other things. You'll have a multimodal risk prediction. And this is some data using that 313 SNP prediction test for the polygenic risk score for breast cancer. And then using this in a very nice data set from Sweden. It was a research study. So they looked at what you get if you combine different things. So they brought in not just polygenic risk score, but age, family history, so-called questionnaire risk factors associated with breast cancer, mammographic density, and then they actually sequenced 9 breast cancer susceptibility genes. So you can see that your prediction goes up as you bring in all the more ingredients, but it doesn't go up that much. And each of these additional chunks of information has challenges to collect. So age is, I always think, is cheating to put that in the score. We know that cancer risk increases as you get older, but it's not just that. It's that if you put the age into the score, the solution you're proposing is that Mrs. Jones starts breast screening at age 53, Mrs. Singh starts breast screening at age 47, Miss Peters starts breast screening at age 51 and a half. You make something, if you're going to use age in your score, you have to use it in your intervention, and that logistically is complicated. Likewise, mammographic density. Mammographic density is really informative, actually not just for your long-term risk, for your short-term risk as well. And they're still unable to do dynamic screening based on mammographic density, so bringing someone back in 1 year or 3 years or whatever based on their mammographic density. And even the research studies have struggled to get early mammograms and incorporate them in the score. So again, it would improve your prediction, but it's logistically very complicated. The questionnaire risk factors are poorly captured in UK Biobank. This notion that they're sitting there in the EPR when a woman had her menarche, how long she breastfed for each of her children, all of these things, again, really complex to capture. They give you a little bit of extra prediction, but I think, again, the statistical geneticists may be a bit optimistic about how easily we could get these data and individualize it and put it with all the other things. And again, sequencing of the susceptibility genes, as I said, remember, they're pretty infrequent, so they give you a bit of extra information, but that's why, because they're relatively infrequent, they're not adding much to your prediction on a population level. So again, you can boost the prediction, but it's at a lot of logistical cost. There's the issue around ancestry. So this is, again, data for breast cancer. This is using that 313 SNP score in UK Biobank. I divert, but it's interesting that actually it performs less well in UK Biobank, and that's some degree of possibly overfitting in terms of, or winner's curse in terms of that initial AUC. But what's actually quite cautionary to note is how much poorer it is in non-European ancestries as well. So you'd have a score that predicts with lower accuracy depending on your ancestry group, which again is a significant implementation issue. This is probably actually the most important issue, is there's no point giving someone a polygenic risk score unless you've got a thing that's really good that you can bolt onto it. And I think that fact, there's lots of people who want to give back everyone's polygenic risk score and tell them about their risk, but actually you need to be able to do something about it. And the thing you do needs to be clinically impactful. It needs to improve cancer mortality. It needs to make you live longer and live better. So a lot of our screening tests are flawed, and there's a sort of rhetoric that somehow magically, if you take the polygenic risk score and bolt it onto a screening test, it will magically ameliorate the problems of the screening test, which is clearly, logically not true. So PSA, problematic screening test, quite poor sensitivity for specificity. Wherever you dial up or down, you get a lot of false positives or false negatives. In particular for prostate screening, wherever you dial up or down, even your positives, a high proportion of those are overdiagnoses. They're labelled prostate cancer, they're indolent disease, they never would have caused that man harm in his lifetime. And that is true to a lesser extent for breast screening, but is still true for thyroid screening and a number of other conditions. Your PRS doesn't solve that. And further, there are screening paradigms which looked promising, but actually when you did the randomised study, there was no benefit in mortality. So ovarian cancer classic case, the CA125 pelvic ultrasound, you got some early suggestion of stage shift, looked like it was working, and then when you followed up, there was no impact on mortality, it was just lead time. You were just finding something earlier, and they died at the same time. Again, that the notion that the PRS is in some way going to change that is misleading and erroneous. And in fact, what's been shown for the breast and prostate cancer PRS, which are the best studied, is that they actually select differentially for good prognosis, indolent disease, which makes sense. The people hanging around and giving samples for genetic research studies were people who didn't have nasty, aggressive, lethal disease. They were the people who had a sort of longer survival and less aggressive disease. And particularly around prostate, a lot of the recruitment was in the States, where people were identified via screening. So the PRS is actually differentiating against the more aggressive disease, where you would have more impact from early diagnosis. And then in terms of the sort of more behavioural response, this is quite poorly studied. Our studies of people who don't have disease and join in screening and risk stratification, these people do not represent the general population. And so the inferences from those groups need to be taken with caution. Uptake of risk stratification, there's a perception people would be desperate to have all this data about their risk and individualised or whatever. And even in PROCAS, which was an existing screening study of breast screening within the NHS, the uptake was 17%. So there are some more studies looking at this, but that people weren't biting the hand of the research study offerer. And these were research engaged people to have their PRS done. We don't know if you tell people that they're at elevated risk of X or low risk of Y, what the impact will be on their health behaviour. Will people at elevated risk of X be anxious? Will they seek more interventions? Will the people who've been told that they're at low risk of breast cancer or cardiovascular disease, will they neglect symptoms? Will they neglect public health preventative measures? All of these are really kind of quite unknown. And ultimately, if you want to redesign screening according to risk, you're going to have to take something away from some people to give it to others, but you'll still get a sizable proportion of cancers in those people that you've taken the screening away from. And I think that is ultimately highly challenging. It is feasible to redesign breast screening, but when you have a sizable number of breast cancers arising in the people that you've either withdrawn or reduced breast screening, you can see in terms of the sort of publicity, that is an issue. Excuse me. How will people interpret their risk? Was well exemplified, many of you will remember, in 2019. Matt Hancock had his polygenic risk score performed for prostate cancer, and he got this nice graph where this line here in blue says 40 to 60% risk. I'd be quite worried about that, actually, but that means the 40 to 60th centile, so that sort of means the average, but I think the presentation of that I would Ben Goldacre might take issue with. So Matt's polygenic risk score is up here, so on sort of about the 80th centile. This is the top 3%, this is the bottom 3%. So he's on about probably the 80th centile, which would convert to a risk to age 75 of 13% for the population on average, and his risk being about 15%. And he announced, I think his people at the briefing were going, Matt, don't. But anyway, he got up there and said, this test has possibly saved my life. I'm going to go straight to my GP and get my prostate cancer screening initiated, not recognising that he was at a sort of 2% absolute lifetime risk above the average, and that there isn't any prostate cancer screening. And this was obviously, of course, when he was Secretary of State for Health. So I think this sort of indicates the maybe the ability of individuals within the population to interpret and juggle this risk, and also giving risk information where there ain't something that you bolt on and do about it. And this is one disease he had his PRS for. The notion is we're going to do maybe 50 and give people back the results. So I'll just work through very quickly a modelled example. So we sort of tried to put together this notion of the polygenic risk score. There's some people who study polygenic risk scores over there. There's some people who study screening over here. And these worlds never come together. And that was sort of what I wanted to try and do. So we took 3 scenarios where screening is sort of hotly debated, going down a decade for breast cancer, down a decade for colorectal cancer, which is already slightly beginning to be introduced. They're trying to do that, but there's not enough capacity using the current national bowel screening. And then screening for prostate cancer, which is a hot topic, and there's a big MRI study recently announced. So these are 3 areas. We don't screen, lots of talk that we should. And then we got all the data together around cancer incidence, age stratified, stage stratified, cancer survival, routes to diagnosis. So what happens when you take people from the standard routes to diagnosis, their stage distribution, and then adjust it for a screening stage distribution with the commensurate survival, and then use population age structure and use the performance from meta-analyses of different screening tools. We made every possible optimistic assumption we could when we did this analysis. So everyone takes up screening. Everyone wants their polygenic risk score. There's no interval cancers in the screening. Screening sensitivity is as good at young age as it is at old, which for mammography is definitely not true. Treatments have not improved since 2008, so that's a necessary assumption. Everyone is European, and the PRS predicts standard prognosis disease. All 7 of those are highly optimistic, but that's what we started with. So we look at the breast example, that age 40 to 49. So again, what happens if we screen the top 20%? And for comparison, say if we just screen the oldest 20%, so those aged 48 to 50, we use our mammograms for them. That's a reason, it's the same resource. And we went through, and the numbers, you can see how many are we missing in the screening group, how many cancers do we get, how many cancers arise in this, do we miss because of the mammography, how many deaths do you avert? So we estimated, with all these benign optimistic assumptions, you'd avert 102 deaths compared to 80 by just screening based on age. What's the reduction in overall deaths? What's the improvement in survival? 1.4%. How many overdiagnoses do you get? You get about 2.4 for each case you find. How many screens do you need to do? That would be the number per year if you did it annually. How many extra biopsies do you need to do? How many individuals do you need to screen to avert 1 death? So we sort of looked at all those metrics. But actually, each time you correct hypothetically for any of these assumptions, for example, if you have a 60 to 70% uptake on screening, it will sort of attenuate that difference between the 2 groups. So the numbers drop, but the gap drops as well. So that difference drops immediately to 15 deaths if you put a realistic estimate on screening uptake. And that's only correcting one of those assumptions. So we sort of presented this in terms of, this is 100 women who present with breast cancer age 40 to 49, and currently there's no screening. If we introduce this top quintile PRS, the ones in grey would have been told they're low risk, so they wouldn't be having any screening. The ones in dark grey would have had screening but be missed on mammography. The ones in yellow would survive or die unchanged. And then the ones in green, you would have changed outcome by screening. And that's with all the optimistic assumptions. And then these are your overdiagnoses. These are women who otherwise would not have had a cancer diagnosis because it was indolent and wouldn't have presented. So again, prostate cancer, you have this issue with the massive proportion of overdiagnoses to lives saved, and then this is colorectal cancer. So it's sort of a simple modelling, and these are the cases of cancer. This doesn't take into account all your false positives and biopsies and so forth. And again, this is cancer-specific, not all-cause mortality. So I'll come to a close. So in summary, I think we need to sort of think of benefits and shortcomings. Polygenic risk scores, there is an AUC, those curves are not overlying. You're dialing up. You will get more cancers for your screening test. You will get bang for buck. That is by definition in terms of the enrichment. But there are costs. It would be an enormous infrastructure to introduce this. There's the ancestry bias. There's the bias towards good prognosis disease. Do people want this? Would they take it up? Would you there be differential groups who don't take up PRS? Would it be a requisite for screening? How do you communicate risks? And ultimately, you still haven't addressed the shortcomings of your screening tools, such as they are. There's quite a lot of tension around PRS, a bit sort of polarised. There's lots of claims from the statistical genetics community and also quite a lot of sort of commercial claims, in terms of sort of marketing, monetising these. So one is that they have sort of quasi-Mendelian risks, but it's also just sort of common sense. So BRCA1 and BRCA2, risk of 60 to 70%. So yes, actually about 1 in 500 women would have a PRS that gives them an odds ratio of above 5. So that's roughly in that ballpark. But we remember BRCA1 and BRCA2, they cause disproportionately young onset breast cancer. They cause disproportionately poor prognosis, ER-negative breast cancer. A lot of these genes are pleomorphic. So actually the BRCA1 and 2 cause ovarian cancer as well as the breast cancer. So you're getting, and that's really where your intervention is most impactful. And also you can cascade in families, and the health economics of rare diseases are often the familial implications. And of course, PRS decay as you, so they're not useful for sort of testing across families. So again, these sort of simplistic claims do need a little bit of thought, I think, before they're put out there. I feel, this was Annika's title, this sums it up from our BMJ analysis piece. Realistic expectations are key to realising the benefits. I think if people make these extraordinary claims, you end up with this very polarised argument. If you recognise they will do a bit and try and figure out whether that bit is useful or not, that is a much more sensible starting place. So I've gone through a number of the issues, the modest heritability, the age distribution, ancestry, the issues around the screening tool and the behavioural responses. And just to acknowledge Cassie and Beth, who helped with the analyses I presented, colleagues at the ICR with whom, and external with whom we've chewed the fat and gone over the data. So thank you for listening.